I wonder if they'll make us put our cameras on.
That'd be cool.
Good morning, good morning, good morning, good morning.
Good morning.
Okay, that's working. All right. And so that's working. All right. Seems to work. That seems to work. Okay. All right, ladies, help me out here. Do the slides move if I do this? Do they move?
Yeah. Mm-hmm.
Okay, good. All right, so we're in the zone.
Perfect.
What?
All right, gang, it's time to start. We're a little thin on the ground here. I had some trouble with people getting on Zoom. I put the link on the Blackboard site and I emailed the link to everybody. So hopefully one of those links works. So let's start with a word of prayer. Lord, thank you for this cold, icy day. We pray you'd keep us safe for those who travel. And now, Lord, this is not an optimal way to do education, but we pray we'd make the most of it. Thank you for these students, for their hard work, and for this time. Please help us make it count. In Jesus' name, amen. All right. If you came to class in your bathrobe and bunny slippers, I don't care. All I care is that you're paying attention. So no need for any testimonials about how you're in your bunny slippers or something like that. we're just doing class today. If you have any questions and you send me a chat note, good chance I won't see it. So just unmute your microphone and just ask me a question. Otherwise, you should probably mute your microphone because the feedback of the speaker through the microphone will cause a lot of distortion. So mute your microphone unless you want to talk. If you want to talk and ask a question, just say, whoa, time out, I don't get that. And then ask your question. This is being recorded. This will go on my YouTube page afterwards, so you can view it later if you want. All right, let's go ahead and begin. We will start first with a little review. So to do that review, we will go to our little makeshift blackboard here. So remember, a mild traumatic brain injury, we also sometimes call it concussion. And your Glasgow Coma Scale for a mild traumatic brain injury is usually between 13 and 15. There's complete loss of consciousness for less than 30 minutes. That's an important demarcation. So if there's no loss of consciousness, or if there's loss of consciousness for less than, there, put some light on the subject, less than 30 minutes, that's an important indicator. Post-traumatic memory loss and change of level of consciousness, that would include things like feeling lethargic or confused. These sorts of changes last for less than a day. So your memory loss, lethargic, confusion, that's less than a day. Your moderate traumatic brain injury, your Glasgow Coma Scale is between 9 and 12. Your loss of consciousness is over 30 minutes, but it's less than 24 hours. Now, in this case, your post-traumatic amnesia or level of consciousness diminution, something like that, will last for anywhere from 1 to 7 days. So that's with post-traumatic amnesia. 1 to 7 days. Your level of consciousness, change in level of consciousness. That will last for more than a day. So that's a moderate traumatic brain injury. When you start to get more than these, you now have a severe brain injury. So now your Glasgow Coma Scale is going to be less than 8. And remember our little mantra, if the GCS is less than 8, it's time to intubate. So you'll need to intubate typically. Now you're going to have loss of consciousness for more than 24 hours. So notice loss of consciousness is about the same. The difference is that Glasgow Coma Scale. Here it's less than 8. And in this case, your post-traumatic amnesia, that's going to last for more than 7 days. And similar to a moderate traumatic brain injury, your change in the level of consciousness will be for more than 24 hours.
Hi, Professor Vadovich.
Yes.
Jade is struggling to join Zoom. I'm on FaceTime with her right and she can like hear the lecture, but she won't be able to join Zoom. Something with her computer's not working.
Okay. The guru is Cynthia Churchwell. Churchwell, Churchwell, one word, Cynthia Churchwell. All I can do is provide the links. There's 20 reasons why the Zoom might not be working. Cynthia can help you figure it out. So have her contact Cynthia Churchwell. Cynthia is in office. She will usually get back to you very quickly.
Okay,
And
thank you.
what she'll do is she'll connect with your computer and figure out usually what's going wrong. It's usually a setting. That's usually what's wrong, in my experience at least. So if you could please give her that advice, I'd much appreciate it.
All righty, thank you.
Yeah. Now, we stopped last time really about there. What is next then in your assessment as the nurse? Next thing you're going to assess will be labs. That color doesn't work very well, does it? Let's try a different color. Labs. That's a little better. So the first lab that you're going to do very, very soon will be a complete blood count. Now, if someone's had a lot of blood loss, you may see some sort of anemia, but the big thing you're looking for here are platelets. Now, you can probably guess why you're so interested in platelets. They've had an injury. They're bleeding. You want to see how well their blood is clotting. So you want this to be greater than 100,000 platelets per microliter. And if it's not at least 100,000 per microliter, you might want to give them platelets. Because without platelets, their blood's not going to clot, excuse me. Next things you're going to look for are the prothrombin time. the prothrombin time test and the prothrombin time. This one tests the extrinsic. Clotting pathway. This one tests the intrinsic. Now, here's the issue with the PTT. Because different reagents can affect the PTT time, you can look this up and put in your reagents and put in the protocol you use. And it will standardize this to what's called an international normalized ratio. INR. And excuse me, in a normal person, the INR should be between 0.9 and 1.3. If it's below that, that means their blood is not going to clot very easily. If it's above that, it means their blood will clot too easily. So the INR is very, very important. The PT on your handout, I have the normal PT times. So this one should be anywhere from, usually it's about 12 seconds. So it's anywhere from here to, on the handout, I think I have 13 and a half. It's around about 14 seconds. Should be in that range. Reason you're doing these is that you're trying to see how well the blood will clot. And if the patient is on any sort of anticoagulants, you hold all anticoagulants and you also reverse them. And they're reversing agents that you can give. You want the patient's blood to clot. If a patient's blood won't clot they're going to bleed to death. Then you're going to get urine toxicology. And you'll do blood alcohol and blood glucose. Blood alcohol, I think for the obvious reason, if they've had an accident, you want to know if ethanol intoxication is the cause of that. If that's the case, they might be an alcoholic, then that's going to influence some of the protocols that you'll take. If they are in some sort of diabetic coma, or if they've had a very high blood sugar and you have some sort of diabetic hyperosmolality, something like that, that's going to affect the types of protocols you'll use. So these are all very important laboratory tests. CBC, going to look particularly at platelets. If your reds are low, if those are low, they might need whole blood, properly cross-typed. That's something to consider. Then the clotting tests, and then urine toxicology, blood alcohol, and blood glucose. So those are very important labs that you need to get. Next thing on the agenda is imaging. So the best imaging you can get will be magnetic resonance imaging. This takes longer than a computerized tomographic scan. So typically, this is your first choice. If you have trouble seeing something on the CT, then you will usually opt for an MRI. So this is usually what you're going to get. With the CT scan, you do a non-contrast scan. And the non-contrast CT scan, you're looking for bleeding. And you are looking for mid-line shifts. What do we mean by a midline shift? So if you have bleeding, say you have an epidural hematoma, that blood is going to push on the brain, and the midline is going to get shifted opposite the direction of the bleed. So the midline that you can see is going to get shifted over. It'll be shifted, and you'll actually see an area here that's not as dense as here. So you have an area of so-called hypodensity. And you'll usually see something instead of the midline being here, the midline gets shifted to over here. That tells you you have a bleed. And the head CT does a very good job of revealing whether or not you have a bleed. That's why the imaging is so important to get, and that's why you do the CT imaging, because it's much faster than an MRI. Now, something that's very important to determine for you, the nurse, you need to make sure that the brain gets proper blood flow. But if the person is bleeding And if there is increased pressure in the brain, that increased pressure is going to take blood vessels and cinch them down. So you want to check, you want to determine something called the cerebral perfusion pressure. Which is mercifully abbreviated CPP. Now, unfortunately, the CPP is not something you can measure directly. So it's measured indirectly, and here's how you measure it. You take the mean arterial pressure and you subtract that from the intracranial pressure. So the mean arterial pressure is the systolic blood pressure and kind of a quick and dirty way to do it is to just subtract the diastolic. That's not exactly what it is. It's a little more complicated than that, but the more specific way to do it is you take, because the heart spends about a third of its time in systole and 2/3 of its time in diastole, you multiply this by a third and multiply that by 2/3. And you subtract these two, and that gives you the mean arterial pressure. But usually it's just, so say somebody's pressure is 120 over 80. It's perfectly reasonable to say, oh, well, the mean arterial pressure is, quick and dirty, is about 40. All right, fine and good. So that's kind of the quick and dirty way. Now, both of these are things you can measure. This you can measure by taking the blood pressure. This you can measure by using a monitor that is inserted into the brain, and it is an intracranial pressure monitor. So these ICP monitors they're inserted through the skull into the ventricle or into the subdural space or something like that. So they can be epidural, they can be put in the brain parenchyma, they can be put in the lateral ventricle, or even the third ventricle of the brain. You usually do this in people whose Glasgow Coma scales are lower than 8. And you're measuring that essentially. So you don't put that in, the surgeon puts that in. Nevertheless, you want the cerebral perfusion pressure to be above 60. If the cerebral perfusion pressure is above 60, that means the brain is getting enough blood. And so to do that, usually you have to keep the systolic blood pressure above 100. And you can do that with blood transfusions. You can do that with intravenous fluids. So keeping that systolic blood pressure above 100 usually will keep this above 60. So normal intracranial pressure is between 10 and 20. That's the normal intracranial pressure. If it's above that, a little trick that nurses like to use to try and lower the intracranial pressure is to take the bed and move the bed. So if this is the bed, you take the bed and you move it up like that. That is called the Fowler's position. Caveat for the Fowler's position is this. Make sure your patient does not have a cervical fracture. Make sure they don't have a cervical spine injury. So do not use if patient has a cervical spine injury. You could probably guess why you wouldn't do that. So if this is, say, a 30, the angle here is anywhere from 30 to 45 degrees, that's Fowler's position. That will increase venous return from the brain. That will lower, so that lowers the intracranial pressure. This Fowler's position, very good for that, but contraindicated if your patient has a cervical spine injury. Something else to consider. The partial pressure of carbon dioxide, when this is high, you get cerebral vasoconstriction. For this reason, in the past, neurologists used to try to get the patient to hyperventilate. That will tend to cause alkalosis. So that's not done anymore. That was done in the past, not done anymore. But that means that the PCO2, if it's low, you will increase cerebral vasodilation. That will increase blood flow to the brain. So this is another trick you can use if you want to increase blood flow to the brain. So you want to keep the PaCO2 pretty much in the normal range. You want to keep that between 35 to 45. I keep writing just 1 M for millimeters. And that's a normal range, and that's pretty much where you want to keep it. You want to try to lower this, lower it just a little bit below 35, not much below that. Other ways to lower, if you want to lower the intracranial pressure, you can use osmotic diuretics. And you do things like mannitol, that's probably the most widely used. You can also use loop diuretics. If you use loop diuretics, word to the wise, watch potassium, because you lose a lot of potassium with loop diuretics. The beauty of them is you lose a lot of liquid. So these can really drop intracranial pressure. They're very good for that, but boy, howdy, watch those electrolytes because you lose a lot of potassium with loop diuretics. Another way you could do that is with hypertonic saline. And the caveat with hypertonic saline, of course, is infuse slowly. You don't want to cause any osmotic shock to neurons, so infuse that slowly. Now, none of you took the bait in the case study, so I'll just say right here, steroids used to be given. Very careful clinical trials have shown that steroids not only don't do any good, they can actually make things worse. So steroids, no steroids. Do not give steroids. Now, if all this, because some of the bleeds that you get with traumatic brain injury are slow. Epidural hematomas tend to bleed fast. And in that case, pretty much nothing you try is going to work. So in the case of fast bleeds, you're going to need to have a decompressive craniotomy. So the patient, just like in your case study, will have to sit there with part of their skull missing. And in this case, your job is infection control. Very, very important. That's your job. If all this still doesn't work, then you essentially go to extreme measures. And these extreme measures involve putting the patient usually in a therapeutic coma. So you can use barbiturates. The beauty of barbiturates is that if the patient has high intracranial pressure and is causing seizures, these drugs are very powerful anti-seizure drugs as well. So you'd use pentobarbital is usually what you'd use. The vet uses pentobarbital to put animals down when they're euthanized, but that's not what they're used for in the hospital. These are used for the barbiturate coma. The other option would be therapeutic hypothermia. So you're cooling the body, you're protecting the brain against secondary injury. This also will drop the metabolism of the brain. You could short-term, and this is done in the ICU, you can use propofol. Nurses in Michigan are now allowed to give propofol. It used to be only an anesthesiologist could give it or a nurse anesthetist. Now, nurses, ICU nurses who are trained to give it can give it. Propofol is going to be short-term. That's only going to be a short-term fix. You don't want people on propofol for too long. So if you are going to have them be sedated for less than a day, this is fine, but not too long. So that's a potential option. All right, let's go over some of the different types of skull fractures that you might experience that can cause a traumatic brain injury. So here we have the occipital bone, and the occipital bone has a tabular area and then a basilar area. And if you get, if you have trauma such that, you have some sort of trauma like this, really hard trauma on top of the head like this, because the brain is sitting essentially on the spinal cord, you can damage essentially this basilar part of the occipital bone. So that's called a basilar fracture. Basilar fracture. If someone has a basilar fracture, something to keep in mind is that a cervical fracture might coexist. So the old song, you can't have one without the other. Well, that's not completely correct. You can have one without the other, but you often don't. So if they have one of these basilar fractures, typically, like peanut butter likes jelly, you're going to have one of these as well. And that should make sense given that this was created by force, blunt force, essentially, coming down on the skull like this, because that force is transmitted into the spinal cord here. You're going to have usually cervical vertebral fractures as well. So if you have a basilar skull fracture, you can see that very easily on a CT scan. These can typically, because they can shake the head up pretty well, you may have vessels that get broken. And the one that's the biggest concern is that middle meningeal artery. The reason this one's of such great concern because it bleeds like nobody's business. And that vessel runs, oh goodness. Okay, let's see. Let's do this. Let's get you a little closer and then let's, okay, focus. All right, I'm gonna assume you can see that. Do you see these sutures here? Those are actually tracks where the middle meningeal vessel lies. And so it lies over this rather thin area of the skull. And if you damage, if this gets shaken up, those vessels will break and they can cause an epidural hematoma. And they really bleed a lot. So that's your middle meningeal vessel tracks here. You can see them kind of continuing. Oh, mercy, get in focus, would you? You can kind of see them continuing here. Oh man, I hope you guys can see that. Let's see, focus. Oh, that's a little better. You can kind of see them there, but if we look at the skull kind of, if you look at the skull as a whole, this part here, that's thin. So you have the confluence of the wings of the sphenoid, the squamous portion of the temporal bone, this thin part here of the parietal bone, That area right there, that's exactly where the MMA tracks, and that's called the pterion. And if that gets damaged, that can shear essentially the middle meningeal vessel. So if you break that middle meningeal vessel, that's bad because you're very likely to have an epidural hematoma. So this, now, don't get me wrong, this doesn't get broken all the time, but essentially check for this. If you have a pool of blood, and that pool of blood usually is kind of lens shaped, different density than the rest of the brain, that means you have a subdural hematoma. That you need to get rid of that fluid, or it's going to push on the brain and you're at risk for herniation. So that you need to deal with right away. If the skull is broken and the bones get depressed inward, that's called a depressed skull fracture. Depressed skull fractures will fold inward into the brain parenchyma. They are clinically important because they directly damage the underlying brain, and these will always require surgery. So that's an immediate surgical consult. Now, another word about the basilar fractures. If you have a basilar skull fracture, you're going to have cerebrospinal fluid leaking out. It leaks out through the nose or the ears, and that increases your meningitis risk. Because that means the barriers around the brain have been breached. And if this is the case, you put gauze over, say, the nose or the ear. Let's make, say, this a piece of gauze. And when you apply that gauze, say, to the ear, what you get on that gauze is you get a clear zone, and then there is blood, because the blood is thicker than the CSF. The CSF goes out first, and then the blood will pool and it'll form this little target like that. That is called a halo sign. If you get a halo sign, that means you have ruptured, usually, the meninges. Okay, I'm throwing a lot at you guys today, so I hope you're hanging with me. And I hope if you have any questions, you'll chime in and ask. All right, now, if you have increased pressure inside the skull, remember that the brain has these foldings of the meninges. There are folds in here, in between the two hemispheres. That's the falx cerebri. And then you have these tentoria that fold in here like this. And these tentoria, they are hard And one of the things that is going to make a path across those tentoria along the wall here of the skull is cranial nerve number 3. So cranial nerve number 3, it has its nuclei in the midbrain. Remember, this is the oculomotor nerve. And the cranial nerves, I hope you remember the mnemonic: on old Olympus' towering tops, the fin in German top. So on old Olympus, olfactory, optic, oculomotor, towering tops, trochlear, trigeminal, abducens, fin, facial, a fin, and auditory, which is actually vestibulocochlear, but we cheat a little, that's okay. A fin and German, glossopharyngeal, viewed, vagus, accessory, hop, hypoglossal. So oculomotor has both motor and parasympathetic inputs. In that midbrain nucleus, you have the motor nucleus. And behind that, you have the parasympathetic nucleus. And the parasympathetic nucleus is called the Edinger-Westphal nucleus. And then this is your motor nucleus. Oh, that's not easy to see. Let's do this. That's a little better. So the eye has these intrinsic muscles involved with moving the eyeball. And all of these, except 2, are innervated by the oculomotor nerve. So you have the superior rectus here. You have the inferior rectus down here. Let's say, for example, this is your left eyeball. If this is the left eyeball, then this is the lateral rectus, and then this over here would be the medial rectus. And then you have 2 obliques. You have a superior oblique up here, and you have an inferior oblique down here. So the superior oblique is innervated by cranial nerve 4. That's the trochlear nerve. The lateral oblique is innervated by the abducens. That's cranial nerve number 6. All the other intrinsic muscles of the eye are innervated by cranial nerve number 3. So essentially the ability to adduct the eye, turn the eye towards the nose, the ability essentially to raise the eye up, raise the eye down. Remember, abduction, that's going to be the abducens, abduction, and then the ability to turn the eye down and in. That's going to be the superior oblique, and that is the trochlear. So if you have damage to the oculomotor nerve, you're going to get 2 things happening. Number 1, the eye is going to be turned because these others aren't working. The abducens takes over and the eye goes out and down, out and down. That's called a down and out eye. Down and out eye. And that's damage to the other piece. If the parasympathetic nerves are damaged as well, then the pupil is dilated. We call that a blown pupil. You'll hear that term in emergency rooms. Sometimes that's what that means. The pupil's dilated. It's a blown pupil. because that sphincter is, you have a plegia with the sphincter. Now, the sympathetic input takes over, and the sympathetic input works unopposed. That's why the eye gets dilated. It can't, so it won't respond to light. You shine light in the eye stays dilated. And here's the thing about the oculomotor nerve, little tidbit about the oculomotor nerve. The motor fibers are in the center, and the parasympathetic fibers are in the periphery. Therefore, if you get any sort of pressure on this, the parasympathetic goes first, and then the motor nerve part goes second. So the parasympathetic loss will be more sensitive than the motor loss. And if you have increased intracranial pressure, because that oculomotor nerve is on the base of, in fact, it comes out right about here. Because that's on the base, if you get pressure, that's one of the first nerves that's going to be affected, will be nerve number 3, cranial nerve number 3. All right, other bits about skull fractures. Skull fractures can be extra-axial or intra-axial. Extra-axial, or they can be intra-axial. What's the difference? Extra-axial injuries are within the skull. Within the skull injuries. So these would include things like epidural and subdural hematomas. They would also include subarachnoid hemorrhages. Intraaxial injuries involve the brain parenchyma. So if the injury involves this, that's intraaxial. So essentially, if you're in the skull, but you're between the skull and the brain parenchyma, that's extraaxial. If you're affecting the brain parenchyma, that's intraaxial. So the intraaxial injuries would include things like intracerebral hemorrhage, and that pencil is giving up the ghost. Let's try this one. Intracerebral hemorrhage, they would also include things like cerebral contusion. And they'd also include something called diffuse axonal injury. Those would be examples of intraaxial injuries. Intracerebral hemorrhage, cerebral contusion, and diffuse axonal injuries. Okay, going through a lot of paper today. Very good. Let's talk about epidural hematomas. So blood now is collecting between the dura mater and the skull periosteum. So blood collects between the dura mater and the skull periosteum. That's an epidural hematoma. The most common epidural hematoma is caused by middle meningeal artery damage. And that pencil's losing it too. My pencils are giving up the ghost. Well, let's try this then. So there's a fair amount of force required to induce an epidural hematoma. So they're more common in younger people who are at risk of such injuries when they play sports or if they get into fights. So people usually will suffer loss of consciousness. Then they will usually go from there to a lucid period. And don't be fooled by this lucid period because bleeding's occurring during that lucid period. The patient will regain consciousness. If it's a really bad epidural hematoma, you may not see this, so you can just say maybe this is optional. And then if the bleed continues to get, if it progresses rapidly, then they will usually lose consciousness again. These particular bleeds, they progress rapidly. And these are the ones most likely to lead to herniation of the brain. And herniation, of course, is very serious. And I hope you guys have watched my little podcast on herniation. All right, so because this is an emergency, there will be edema or swelling in the brain. And so the way to get rid of this is by virtue of a craniotomy. You remove part of a skull and you let the blood essentially evacuate from the brain while the healing occurs. If there is an emergency and you can't get the OR for this, something you can do in the emergency room is something called burr trephination. That's done with one of these little roto-rooter looking things. It's a kind of a drill. With a trigger, and it has one of these teeth on it things, and that thing, goes around at high speed, and you drill that thing in the skull, and that's how that works. So that's called burr trephination. You can save someone's life with that. If the epidermal hematoma is smaller than 30 millimeters in size, so if it's smaller than 30 millimeters in size, then surgery may not be warranted. Also, if the midline shift is less than 5 millimeters, then surgery is not warranted. Also, if the Glasgow Coma Scale is greater than 8, all of these dictate that surgery is not warranted. This is a wait and see sort of thing. If it gets below that, then you do surgery. So that's a subdural hematoma. Let's now talk about an epidural hematoma. Epidural hematomas, the bleeding is due to what are called bridging veins.
Dr. Branovich,
Yes, ma'am.
didn't we just do epidural hematomas?
Oh, crumbs. You're right. Okay, one of these days I'll learn how to read. Subdural. They're not on top of it's not between the skull and the dura, it's underneath the dura. So this is due to tearing of the bridging veins. Now, because your source of bleeding are veins are under lower pressure than arteries. So these, they don't bleed nearly as quickly. So these can be acute. Boy, that color doesn't come out very well, does it? Let's try a different color that you can see a little better. They can be considered acute if they develop within 2 days of a head trauma. So that would be anywhere between 2 to 4 days. So that 2 to 4 day range, then it's acute. And if it develops between 2 days and 2 weeks of the head trauma, 2 days to 2 weeks, then it's considered subacute. And if it develops more than 2 weeks after the head trauma, then it's considered chronic. You can get these, and here's the thing about a subdural hematoma. As you age, the brain shrinks. Because the brain shrinks, the brain is going to flop around more in the skull. So the brain, then there's going to be more flopping around in the skull. So say you're getting out of the car and you bump your head, or you're trying to climb into somebody's tiny VW, whatever, and you whack your head. When you're younger, your brain's not going to move that much. As you get older, it's going to move around more, and you're much more likely to tear those bridging veins. So these are much more common in older people. Much more common in older people. So the two people groups at risk for this type of bleed are older patients, and the other group whose brains have shrunk, alcoholics. And mild brain trauma can cause these. You also see these in children, particularly infants who've undergone child abuse. And if you see a subdural hematoma in a child and an infant, you should suspect, not jump to automatically, but suspect child abuse. You should look for other things. Like, again, the big thing will be the retina in that case. Because when you shake the little tyke, essentially the brain does that, and that tears the bridging veins, essentially. All right. That's all we have time for today. We'll finish this and then we'll get into strokes and demyelinating diseases in the brain. And don't forget, provided we're in class, we'll have a quiz. And I have another class, of course, to get to, but I hope you guys have a terrific rest of the day. You get a bit of a reprieve today, so use this time to catch up and maybe spend some time praying, reading your Bible, something like that. So there we are. All right. You guys all have a great day. I will see you.
Thank
hopefully.
you.
Oh, yes, of course. Of course.
Thank you.
Thank you.
Right.